Usually when we talk about medical diagnosis, there is this comforting expectation of precision.
Right, it feels almost like engineering.
Exactly. Like you break your arm, you go to the hospital, and the X-ray shows that jagged white line on the radius bone.
And the doctor just points to the screen and says, there it is. That is the problem.
Yeah, visual evidence gives you a sense of certainty. We rely so heavily on things we can see or measure and just put into neat binary boxes.
Broken or intact, infected or sterile.
But then you step into the world of neurodevelopment, trauma, and behavioral health, and suddenly that X-ray machine is utterly useless.
Oh, completely useless.
We find ourselves looking at a diagnostic landscape that is incredibly murky. I mean, you cannot draw blood to quantify a patient's grief.
Oh, you can't.
And you certainly cannot run a scan to see the exact moment a family's communication boundaries became enmeshed.
And that ambiguity, that is often the greatest hurdle for new clinicians.
Oh, I bet.
You are navigating the absolute definition of diagnostic muddy waters. The symptoms are behavioral, the etiology is often hidden in a lifetime of experiences, and, well, the treatments require a fundamental rewiring of how a person interacts with reality.
And that murky, complex, fascinating reality is exactly where we are heading today. Welcome to the deep dive.
We are so glad to be here with you.
We are talking directly to you, the learner, the nursing student, the future healthcare professional who's standing on the precipice, about to step onto an acute care mental health unit.
It is a big step.
Huge. And today we are tackling a massive, incredibly vital stack of source material from your curriculum. We're looking at ATI Unit 2, Part 2.
Which covers traditional non-pharmacological therapies.
Right. Because medications play an undeniably crucial role in stabilizing severe psychiatric conditions, obviously.
Yeah, they provide the neurochemical foundation for recovery.
But relying solely on pharmacology is like putting a cast on that broken arm, but never doing the physical therapy to regain mobility.
That is a great analogy. The non-pharmacological tools are what actually teach the patient how to live and cope and thrive again.
So our mission for this deep dive is to serve as your ultimate comprehensive audio study guide. We have chapters covering the evolution of psychotherapy, group and family dynamics, stress management, and brain stimulation therapies.
It is a lot of ground to cover.
It really is. We're going to extract the priority nursing interventions, decode how these therapies actually play out on the floor during a chaotic shift, and highlight the underlying mechanisms you absolutely need to understand for clinical practice and, of course, for exam recall.
Because the exam is looming, right?
Always.
Okay.
Let's unpack this. Because while psych meds get a lot of the glory, the interpersonal and behavioral tools in your nursing toolkit are often the true catalysts for a patient's transformation.
What's really fascinating here is that the goal is not just rote memorization of therapy definitions.
No, not at all.
To be an effective mental health nurse, you must understand the architecture of these interventions. We need to explore the underlying mechanics of the human mind, the biological responses to trauma, and how you actively apply these therapeutic frameworks to guide someone back from the edge of crisis.
So we have to start with the foundational unit of mental health, which is the individual mind.
Right, before we get to groups.
Exactly. Before we look at how people clash in groups or families, we need to understand how we treat the solitary human being. And that approach has undergone a massive evolution.
It really has. From Freud's couch to the modern acute care milieu?
Yeah, the shift over the last century is just staggering. If we look at classical psychoanalysis, the theoretical foundation built by Freud back in the late 19th and early 20th centuries, it is essentially a therapeutic excavation.
Excavation is the perfect word for it. The process revolves around assessing deeply buried unconscious thoughts and feelings to resolve internal conflicts. The core tenet of this approach is that these internal conflicts almost exclusively stem from early childhood experiences and unresolved developmental stages.
And the classic image is burned into our cultural consciousness, right?
Yeah.
The patient lying back, staring at the ceiling, engaging in free association.
Just speaking every uncensored thought that drifts through their mind.
Exactly. While the analyst sits out of sight, taking notes about the patient's mother. And the timeline for this kind of therapy is just staggering.
Oh, it is. The texts note this involves multiple sessions a week. stretching over the course of many months, sometimes even years.
Years. I mean, the commitment required is immense.
Because dismantling the ego's defenses to access the unconscious cannot be rushed.
That makes sense.
And this prolonged, intense vulnerability brings up two incredibly important concepts that are, without a doubt, guaranteed to appear on your exams.
Ah, transference and countertransference.
Exactly. While these phenomena happen in all therapeutic settings, classical psychoanalysis is where they were first deeply analyzed and utilized as tools.
So let's break those down.
Transference occurs when the client unconsciously develops feelings toward the therapist that are actually related to similar feelings toward significant people in the client's early childhood.
Okay, let's paint a picture of how this actually looks on an acute care floor. Imagine you are a nurse doing a routine morning assessment.
Okay.
You use a slightly firm, authoritative tone of voice to ask a patient to get out of bed for breakfast.
A very normal nursing task.
Right. But suddenly, the patient becomes intensely hostile, verbally abusive, and terrified. You haven't done anything wrong, but your tone of voice unknowingly mirrored the exact cadence of the patient's abusive father.
Wow. Yes.
The patient is experiencing transference. They are taking the emotional weight of that past relationship and projecting it directly onto you in the present moment.
And the clinical danger arises if you, the nurse, take that hostility personally and react with anger or defensiveness.
Because it feels like a personal attack.
It does. But understanding transference allows you to step back. Recognize that you are just a stand-in for a ghost from their past and respond therapeutically rather than punitively.
That is such a vital skill. And the inverse of this dynamic is equally critical.
Yes, countertransference. That is the unconscious emotional reaction the healthcare worker has toward the client.
And this is where boundary issues often originate, right?
Almost always.
So say you have an elderly patient suffering from severe depression, and she happens to smell like the specific floral perfume your beloved late grandmother used to wear.
Oh, that is a classic trigger.
Right. Without realizing it, you start feeling deeply protective of this patient. You start bending unit rules, maybe sneaking her extra snacks or letting her stay up past lights out, while strictly enforcing the rules for everyone else.
And the really insidious nature of countertransference is that it feels justified in the moment.
Yeah, you just feel like you're being nice. Yeah.
You believe you are just being compassionate, but you are actually compromising your professional objectivity and potentially harming the therapeutic milieu by displaying favoritism.
Which other patients will absolutely notice.
They always do. Both transference and countertransference operate below the level of conscious awareness. The priority nursing intervention here is constant self-reflection and utilizing clinical supervision to identify these blind spots before they compromise care.
Okay, so given how the modern healthcare system operates today, with insurance companies tightly restricting the number of approved therapy sessions, it seems impossible that anyone actually undergoes classical psychoanalysis today.
It is very rare.
Do clinicians still rely on techniques like free association or intensive dream analysis?
As your text explicitly notes, classical psychoanalysis is highly unlikely to be the sole therapy of choice today.
I would imagine not.
The sheer length of therapy, combined with health insurance constraints and the need for rapid stabilization in acute settings, makes it totally impractical. The field has largely pivoted to more targeted forms of modern psychotherapy.
By psychodynamic psychotherapy,
Right.
Which is sort of the direct descendant.
Exactly. It utilizes similar tools to psychoanalysis, recognizing the impact of the unconscious and the past, but it focuses much more intently on the client's present state and current coping mechanisms rather than digging endlessly into early childhood trauma.
And the therapist is also much more active and engaged in psychodynamic therapy rather than sitting silently out of view.
Yes, it is much more of a dialogue. Another major modern approach is interpersonal psychotherapy, or IPT.
Oh, I like IPT. The underlying premise is highly practical.
It is. The premise is that mental health disorders are heavily influenced by interpersonal interactions and the immediate social context.
So the focus shifts from the internal to the external. IPT assists clients in addressing specific, tangible problems.
Like what?
Well, the text highlights improving interpersonal relationships, enhancing communication skills, and navigating role transitions or complex bereavement.
Right. The therapeutic goal of IPT is not profound psychological insight into the origins of one's personality. The goal is improving daily social functioning to reduce psychiatric manifestations.
So if a patient's depression is triggered by a toxic dynamic at work, IPT focuses on giving them the tools to navigate that specific dynamic.
And that, in turn, alleviates the depressive symptoms.
Exactly. But even with IPT, the foundation is still verbal interaction. We are still sitting in a room talking about feelings, relationships, and internal states.
This is very traditional.
But here's where it gets really interesting. Not everyone in the history of psychology agreed with the whole, let's talk about our feelings approach.
Oh, definitely not.
This brings us to a massive paradigm shift. The behavioral theorists,
Yes, Ivan Pavlov, John B. Watson, and B.F. Skinner. They fundamentally rejected the psychoanalytic focus on the unobservable unconscious mind.
they were not fans of Freud.
No, they argued that if psychology was to be a true science, it must focus exclusively on observable, measurable behavior.
They essentially looked at Freud's theories and said, we cannot measure your dreams, we cannot see your id or your ego, and we frankly do not care about your early childhood internal conflicts.
Right. Their revolutionary theory posited that all behavior, both adaptive and maladaptive, is simply learned through interaction with the environment.
Abnormal behavior is not a symptom of a deep unconscious neurosis.
No, it is simply a learned response, often an attempt to avoid painful stimuli. Therefore, their radical proposition was this: you do not need profound insight into the underlying historical cause of a behavior to change the behavior.
You merely need to alter the learning pattern.
Exactly.
That shifts the entire landscape from an exploratory excavation to an active construction site. It is the ultimate action plan.
It really is. Behavioral therapies teach clients specific, tangible ways to decrease anxiety or extinguish avoidant behavior, providing immediate opportunities to practice these new skills.
So let's look at how these key interventions materialize in an acute care setting, starting with modeling.
Modeling relies on observational learning. The therapist, the nurse, or even a highly functioning peer serves as a role model for a client, demonstrating appropriate behavior in a stressful situation.
And the client observes the process and the positive outcome, which encourages them to imitate the behavior.
Exactly.
Imagine a crowded, chaotic day room on an acute psychiatric unit. You have a patient who suffers from severe social anxiety and tends to become verbally aggressive when they feel crowded or overwhelmed.
A very common scenario.
Right. Instead of pulling them into a room to analyze why crowds frighten them, the nurse deliberately role-plays a stressful scenario.
Oh, I see.
The nurse physically demonstrates how to stop, take a deep, grounding breath, and use a calm, assertive voice to say, I'm feeling overwhelmed right now. I need to step back and have some space.
And the client watches the nurse model this emotional regulation.
Exactly, and the practice is imitating it.
The neurological basis for modeling likely involves the mirror neuron system in the brain, which fires both when we perform an action and when we observe someone else performing that same action.
It is a highly efficient way to acquire new coping mechanisms.
And another foundational pillar of this approach is operant conditioning, which relies on the principle that behaviors followed by positive consequences are more likely to be repeated.
This involves establishing a system of positive reinforcement. Your text provides a brilliant active learning scenario for this.
Let's walk through it.
Let's imagine you are caring for a patient diagnosed with a severe personality disorder. This patient absolutely refuses to attend unit group meetings, will not participate in milieu therapy, and spends the entire day isolated in their room.
Okay.
However, through your nursing assessment, you discover they crave one-on-one interaction with the staff and constantly request to take a daily supervised walk outside in the courtyard.
Ah, so you have a motivator.
Exactly. The provider prescribes behavioral therapy utilizing operant conditioning.
So what is the nursing intervention here? The most effective intervention is the implementation of a token economy. The nursing staff uses tokens, tallies, or a specific point system to reward the client immediately following positive changes in behavior.
So if the therapeutic goal is for the client to decrease isolation and attend group therapy,
Then the client earns a set number of tokens for every group session they attend.
the genius of the token economy is that it bypasses the patient's resistance and avoids power struggles. You are not arguing with them about the benefits of socialization.
No, you are simply changing the currency of the unit.
Right. They take the tokens they earned by attending group and they cash them in for the reward they highly value, which is the walk outside with the staff member.
You are actively building a new, healthier pattern of action through consistent reinforcement. It creates a structured environment where expectations and consequences are entirely predictable.
Now, a different behavioral approach is required when the maladaptive behavior is an intense, paralyzing phobia. This requires us to examine systematic desensitization versus flooding.
Yes, and these two approaches sound fundamentally opposite, even though they share the same goal of extinguishing a fear response.
So let's start with systematic desensitization. That's a planned, graduated, progressive exposure to an anxiety-provoking stimulus paired with intense relaxation techniques.
Let's apply this to a patient with an extreme, debilitating fear of elevators, which is severely limiting their ability to work or travel.
Okay, so first, the nurse or therapist spends significant time helping the client master deep diaphragmatic breathing and progressive muscle relaxation.
Establishing that baseline ability to self-soothe is absolutely critical. Only then does the exposure begin, starting at the absolute lowest level of the patient's fear hierarchy.
So the patient might sit in a comfortable chair, utilize their relaxation techniques, and simply imagine the doors of an elevator.
Just imagine them.
Right. Once they can do that without their heart racing, they move up a step, they look at a photograph of an elevator.
And then, perhaps days later, they walk into a building and stand 30 feet away from an elevator bank.
Then they stand right in front of the closed doors. Finally, they step inside and ride it up one floor. At every single step, they use their learned relaxation techniques to actively suppress the sympathetic nervous system's anxiety response.
The physiological mechanism here is reciprocal inhibition. The body cannot be in a state of deep relaxation and a state of intense panic simultaneously.
That makes total sense. So the client slowly builds tolerance, step by step, until the stimulus no longer triggers the fight or flight cascade.
Right. Flooding, on the other hand, bypasses the graduated hierarchy entirely.
Yeah, flooding sounds like the psychological equivalent of ripping off a bandage.
It does.
It involves exposing a client to a massive amount of the undesirable stimulus all at once, aiming to simply short-circuit and turn off the anxiety response. But taking a patient who is terrified of elevators and locking them in an elevator for an hour seems absolutely terrifying. Is this actually safe?
It is highly distressing, which is why it requires strict ethical oversight and must only be conducted by a highly trained therapist in a controlled environment.
How does it even work?
Well, we can understand the mechanism of flooding by thinking about a loud, blaring car alarm outside your bedroom window. At first, the noise is deafening, jarring, and impossible to ignore. It spikes your adrenaline.
Oh yeah, it drives you crazy.
But if that alarm rings continuously for an hour, your brain eventually realizes there is no actual immediate danger. The nervous system habituates to the noise, and you eventually tune it out.
Ah, because the physiological fight or flight response requires massive amounts of energy. The body simply cannot maintain a state of absolute peak panic indefinitely.
Precisely. Eventually, the adrenaline and cortisol deplete, the parasympathetic nervous system kicks in to protect the body from exhaustion, and the anxiety naturally diminishes, even in the presence of the feared object.
But what if they try to run away?
Well, that's the critical element of flooding. The therapist must prevent the client from escaping the situation before the anxiety naturally recedes. Because if the patient panics and escapes the elevator after 5 minutes while their anxiety is peaking, the escape itself becomes a massive negative reinforcement. Their brain learns, I escaped the elevator and my anxiety dropped. Therefore, the elevator truly is dangerous.
Oh, wow.
So the exposure must last long enough for the physiological exhaustion to occur, proving to the brain that the situation is actually safe.
That is intense. And then we have aversion therapy, which takes a different route entirely. Instead of extinguishing fear, it aims to extinguish a harmful behavior by actively pairing it with an intensely unpleasant stimulus.
Right. The text mentions utilizing a bitter taste on the fingernails to stop severe thumb-sucking, or even applying a mild controlled electric shock to deter severe, life-threatening self-mutilation behaviors in specific populations.
For the nursing students listening, there's a critical safety and ethical point here. If a treatment team is utilizing aversion therapy, the priority nursing intervention is continuous, ongoing supervision and rigorous evaluation.
You cannot just set it and forget it.
Exactly. You cannot simply apply a punishing stimulus and walk away. You must monitor the patient's physical and psychological response constantly to ensure the treatment is not causing undue harm or trauma.
Safety, informed consent, and strict adherence to ethical boundaries are paramount when utilizing any aversive techniques.
All right, let's contextualize this with some clinical hypotheticals that mirror what you will face on the NCLEX.
Okay, lay them on me.
Imagine you are reviewing a care plan for a client diagnosed with generalized anxiety disorder who is scheduled to begin classical psychoanalysis.
Okay.
If you are evaluating the client's understanding of this treatment, which statement would reassure you that they comprehend the process? Would it be their expectation that the therapy will conclude in 6 weeks? Or perhaps their belief that the therapist will focus heavily on changing their current behaviors.
Well, neither of those statements reflects classical psychoanalysis. A patient who understands psychoanalysis will state that the therapist will focus heavily on exploring their past relationships and early childhood experiences.
Because expecting a 6-week resolution is wildly inaccurate for a therapy that takes months or years.
Exactly. And focusing purely on changing current behaviors describes behavioral therapy, not the unconscious excavation of psychoanalysis.
Right. Okay. What if you are administering a new prescription for disulfiram to a client with a severe alcohol use disorder?
And abuse.
Yes, you are providing medication education, explaining that if they consume even a drop of alcohol while on this medication, they will experience severe, violently unpleasant nausea, vomiting, and palpitations. What behavioral treatment paradigm does this medication represent?
The administration of disulfiram is a textbook pharmacological application of aversion therapy. You are deliberately pairing the maladaptive behavior, which is the consumption of alcohol, with an intensely aversive physiological reaction.
The goal is that the brain will eventually associate the sight or smell of alcohol with the memory of violent nausea, thereby extinguishing the craving. Okay, one more. If a nursing instructor asks you to select cognitive reframing techniques from a list of interventions, you have to be highly specific.
Oh, this is a tricky one.
Say your options include priority restructuring, monitoring thoughts, diaphragmatic breathing, journal keeping, and meditation.
The trap here is confusing cognitive interventions with behavioral ones. Cognitive reframing strictly targets the mechanics of thought.
So, priority restructuring, actively monitoring thoughts for cognitive distortions, and journal keeping to track emotional triggers are all cognitive techniques.
Correct. Diaphragmatic breathing and meditation, while excellent therapies, are physiological and behavioral relaxation techniques. They do not inherently reframe the cognitive structure of a thought.
You really have to know the precise categories of your interventions.
You do.
Because treating the individual mind, whether through analyzing transference or implementing a token economy, is incredibly complex.
Well,
But human beings are social creatures. We do not exist in a vacuum.
no, we live in tangled webs of relationships, families, and communities.
So what happens when we take these individual psychological mechanisms and drop them into a group setting? Let's transition into the dynamics of the social web.
Group and family therapy introduce entirely new variables into the therapeutic equation. In a group setting, the focus fundamentally shifts. It is no longer solely about generating individual insight. It leverages the power of the collective.
Right.
One of the most profound therapeutic factors of group work, as identified by psychiatric theorist Irvin Yalom, is universality.
Universality. I love that concept.
It's powerful. Group therapy allows individuals to discover that they are not entirely alone in their suffering. Recognizing that other members share similar terrifying feelings, traumatic experiences, or intrusive thoughts significantly diminishes the profound isolation that accompanies mental illness.
But dropping 8 people with varying psychiatric diagnoses into a room together and expecting healing to occur spontaneously is a recipe for disaster.
Oh, absolute disaster.
For a group to be therapeutic, it requires a leader to orchestrate the process. The text outlines 3 distinct leadership styles that you must know for exam recall, as they dictate the entire culture of the group: democratic, laissez-faire, and autocratic.
Democratic leadership is widely considered the gold standard in most therapeutic group settings.
Because it's balanced.
Exactly. A democratic leader supports extensive group interaction and actively involves members in decision-making and problem-solving. The leader guides the process, ensures boundaries are maintained, but empowers the members to take ownership of their recovery. It fosters a highly collaborative and respectful environment.
Conversely, laissez-faire leadership takes a completely hands-off approach. The term translates to let it be.
Yes, the leader makes virtually no attempt to control the direction, structure, or content of the group.
So the group progresses without any formal direction. I can imagine this going in one of 2 ways. Either it becomes a profound space for organic, self-directed growth among highly motivated individuals, or it devolves into absolute chaos.
In an acute inpatient psychiatric setting, where patients are highly dysregulated and struggling with impulse control, a laissez-faire approach almost always leans toward chaos and is generally contraindicated.
Makes sense.
However, in highly functioning, specialized outpatient groups, such as an established group of artists utilizing art therapy, it might have a place.
And finally, we have autocratic leadership, where the leader completely dictates the direction, structure, and rules of the group without allowing for meaningful group interaction or democratic decision-making.
It sounds like a strict professor running a rigid lecture hall rather than a therapy session.
Yeah, exactly. While it might be necessary for a brief educational group on unit rules, it severely limits interpersonal processing.
Now, regardless of the leadership style, whenever a group forms, underlying dynamics inevitably emerge. The text highlights the concept of hidden agendas.
Oh, hidden agendas are fascinating. This occurs when individual members harbor personal goals that are entirely different from the stated therapeutic goals of the group.
Give us an example.
Well, for example, the stated goal of a group might be anger management, but perhaps 3 members have a hidden agenda. They secretly form an alliance with the sole purpose of mocking and embarrassing another group member they dislike.
And those hidden agendas are toxic to the therapeutic milieu. They breed distrust and prevent genuine vulnerability.
Yeah, they do.
And these hidden agendas frequently manifest through the formation of subgroups. Those are small, exclusive cliques of individuals within the larger group who function separately, often whispering among themselves or refusing to interact with those outside their clique.
Identifying and dismantling these subgroups by bringing their hidden agendas to light is a primary responsibility of a democratic group leader.
Yeah, absolutely.
Understanding how a group navigates these challenges requires knowing the life cycle of the group itself. A therapeutic group does not just start and stop. It evolves. There are 3 specific phases of group development that are absolutely critical for your understanding and for the NCLEX.
The life cycle begins with the orientation phase. When a group first convenes, anxiety is typically high. The primary focus of the nurse or leader in this phase is foundational, defining the precise purpose and goals of the group.
Right.
The leader sets a tone of mutual respect, explicitly establishes the rules of confidentiality, and facilitates introductions so members can begin to know each other.
But there is a massive, counterintuitive exam alert hidden in the orientation phase. In addition to setting rules and doing introductions, the leader must explicitly discuss termination.
Yes.
You have to talk about the end of the group on the very first day. Why on earth do we introduce the concept of saying goodbye before anyone has even unpacked their issues? It feels like starting a first date by talking about a potential divorce.
I know, it sounds strange. But the clinical reasoning behind this is profound, especially when considering the patient population. Many individuals seeking psychiatric care carry deep, unhealed trauma related to abandonment, sudden loss, or wildly unpredictable endings to relationships. If you allow a patient to form a deep emotional attachment to a therapy group and then suddenly announce the group is ending in a week, you risk triggering a massive abandonment response that can undo all the therapeutic progress.
That makes so much sense. By discussing termination during the very first meeting, you establish a clear, safe, and highly predictable boundary.
You are effectively telling the patient, this is a temporary, protected space for us to do difficult work. It will eventually end, and we are going to spend our time preparing for that ending together. It removes the anxiety of the unknown.
That reframes it completely. It is an act of clinical safety, not pessimism.
Precisely.
Once the foundation is laid, the group moves into the working phase. This is where the heavy lifting occurs. The group focuses on actively promoting problem solving, facilitating behavioral changes, and challenging maladaptive thoughts.
Because the members are now comfortable enough to push boundaries, this is also the phase where power and control issues inevitably pop up. Members begin to take on informal roles within the group dynamic.
And observing these informal roles provides immense diagnostic insight, doesn't it?
It really does. You might observe a member adopt a maintenance role, acting as the group harmonizer who constantly tries to smooth over conflict and ensure everyone feels heard.
Right.
Conversely, someone might adopt an individual role, such as the dominator, who constantly interrupts, monopolizes the conversation, and tries to control the narrative.
And the leader must navigate these roles, empowering the harmonizer while setting firm limits on the dominator to ensure equity in the group.
Exactly.
Finally, the group reaches the termination phase. The therapeutic work is summarized, individual and collective contributions are acknowledged, and the members process their feelings regarding the end of the group experience.
Which brings us to the most intense, deeply ingrained group dynamic of all, the family.
Oh boy. Family therapy.
The family is arguably the most influential system an individual will ever belong to. It shapes our initial understanding of reality, communication, and self-worth. Yes, and in family therapy, the clinical lens shifts dramatically. The focus is incredibly specific. The nurse or therapist is treating the family as a complex, interconnected system, not focusing solely on the individual members.
So if a family brings in a teenager suffering from severe depression, the family therapy approach doesn't just focus on fixing the teenager's brain chemistry.
No. It zooms out to examine how the parents' communication styles, the sibling rivalries, and the overall family boundaries might be contributing to or failing to adequately support the teenager's condition.
The teenager is seen as the identified patient, carrying the symptom for a larger systemic illness.
That's a great way to put it.
But families are messy. People argue. Doors get slammed. How does a nurse differentiate between a normal, heated family disagreement and actual clinically significant dysfunction?
The distinction lies in the patterns of communication and the rigidity of the boundaries. Healthy families experience conflict, absolutely. But they possess clear, direct communication, they eventually find ways to agree on important management issues, and they maintain clear boundaries that respect individual autonomy.
Whereas dysfunctional families repeatedly fall into specific, unhealthy patterns that prevent resolution and cause chronic emotional harm.
Exactly. The text highlights 5 specific dysfunctional communication patterns that you must be able to identify.
Let's examine these closely because they're painfully recognizable. First is blaming.
Blaming is a defense mechanism where a member shifts the focus away from their own inadequacies or mistakes by aggressively blaming someone else for the family's problems. It destroys accountability.
Right. Second is manipulating.
This involves using dishonesty, emotional coercion, or trickery to support a personal agenda rather than communicating needs directly.
Third is placating. This one is fascinating because it looks harmless on the surface.
But placating is highly damaging. This is when one member consistently takes all the responsibility and blame for every problem, regardless of fault, simply to keep the peace at all costs.
They become the family martyr, chronically suppressing their own needs to prevent anyone else from getting angry.
And it creates deep internal resentment.
Fourth is distracting.
When the family attempts to engage in genuine problem-solving regarding a difficult issue, a member using distraction will constantly insert irrelevant information, change the subject, or create a minor crisis to avoid dealing with the actual painful reality.
And the fifth is generalizing.
This is the weaponization of absolute terms like always and never. Statements like, you always ruin family vacations, you never listen to a word I say.
Generalizing attacks the person's character rather than addressing a specific behavior, which instantly shuts down any possibility of actual communication and forces the other person into a defensive posture.
Beyond these toxic communication styles, the NCLEX heavily tests your understanding of family boundaries. You need to distinguish clearly between enmeshed and rigid boundaries.
Okay, let's start with enmeshed boundaries. That occurs when the thoughts, roles, and emotional feelings of family members blend so entirely that individual identities are virtually lost. There is a total lack of independence.
A classic example is parentification, where a parent relies on a young child for deep, complex emotional support, effectively treating the child like a peer or a spouse.
Ah, that's so tough.
The child's individual developmental needs are consumed by the parent's emotional demands.
It's emotional suffocation masquerading as closeness.
Yes.
Rigid boundaries are the exact opposite extreme.
In a family with rigid boundaries, the rules and roles are completely inflexible and non-negotiable. Members isolate themselves from one another.
Communication is minimal, superficial, and strictly functional. They do not share deep thoughts, fears, or feelings, leading to an environment that is emotionally barren and profoundly lonely.
There are 2 more critical exam keywords regarding family dysfunction: scapegoating and triangulation.
Scapegoating is the process of displacing the family's collective frustration and dysfunction onto the member with the least amount of power, effectively blaming them for everything.
The text gives the example of blaming one child who forgot to do their chores for the reason the entire family is unhappy and cannot go to the movies.
The psychological mechanism of scapegoating is incredibly potent. By focusing all their anger on the scapegoat, the rest of the family members can avoid looking at their own deep-seated issues or marital failures.
The family essentially needs the scapegoat to be the problem so the rest of the system can pretend to be healthy.
And triangulation is equally destructive. This occurs when a third party is drawn into a highly conflicted or unstable relationship between 2 other members.
The geometry of this is toxic. Imagine 2 parents whose marriage is deeply unstable and fraught with constant unresolved conflict. Instead of dealing with each other, the mother forms a tight, inappropriate alliance with her teenage daughter.
So the mother constantly complains to the daughter about how terrible the father is, effectively freezing the father out and forcing the daughter to take a side. The daughter is now triangulated.
And the tragedy of triangulation is that it temporarily decreases the acute anxiety between the two original conflicting parties, the parents, but it does so by injecting extreme anxiety into the third party, the child.
It completely prevents the parents from ever actually resolving their marital issues.
Let's test this knowledge with some clinical scenarios.
Good idea.
Imagine you are leading the initial orientation meeting of a bereavement support group. As the nurse leader, what are your absolute priority actions during this first hour?
Okay, you must define the purpose of the group, establish strict rules for confidentiality, and crucially, discuss the eventual termination of the group.
The distinction to remember here is what you do not do during orientation. You do not attempt to formally identify informal roles like the dominator or the harmonizer.
Because those roles have not yet organically formed. They emerge during the working phase, once the initial anxiety settles and the true group dynamics begin playing out.
Right. Okay, suppose a family is in therapy, and the parents describe a recurring issue. Their younger son frequently creates elaborate lies to make his older sister look bad in front of the parents, specifically so the younger son will receive more privileges and the sister will be punished. What specific dysfunctional behavior is this?
It is a clear presentation of manipulation. The younger child is actively utilizing dishonesty and trickery to maneuver the system to support their own agenda.
Yeah.
It goes beyond simple blaming because it involves the active creation of a deceptive scenario.
Yeah, exactly.
Navigating a family unit plagued by manipulation, enmeshed boundaries, and triangulation is exhausting. Simply existing in that kind of environment triggers the body's ultimate biological alarm system, stress.
Oh, yes.
This brings us to a profound physiological transition. How do nurses assess the biological damage of stress? And more importantly, how do they teach patients to mitigate it?
To understand the interventions, we must first dive into the biological reality of the stress response. Hans Selye's general adaptation syndrome teaches us that stress is biologically nonspecific.
Nonspecific, meaning it reacts the same way regardless of the cause.
Yes. Whether an individual is experiencing a good stressor, such as planning a massive wedding or starting a demanding new dream job, or a bad stressor, such as facing a severe illness or enduring an abusive relationship, the body interprets the demand for adaptation in the exact same way.
It activates the hypothalamic pituitary adrenal axis, the HPA axis, and the sympathetic nervous system, initiating the fight-or-flight cascade.
Your textbook makes a massive, clinically vital distinction between acute stress, the immediate fight-or-flight response, and prolonged maladaptive stress.
Let's break down the expected biological findings for acute stress first.
In the acute phase, the brain perceives an immediate threat. The adrenal glands dump massive amounts of epinephrine and norepinephrine into the bloodstream. You observe intense psychological apprehension, unhappiness, and a sudden, sharply decreased appetite.
Because physiologically, the body is preparing for intense physical exertion to survive a literal threat.
Therefore, you see an immediate increase in respiratory rate to take in more oxygen, a spike in heart rate and cardiac output to pump that oxygenated blood to the large muscle groups, and a subsequent spike in blood pressure.
And the liver releases stored glycogen, increasing metabolism and glucose use to ensure the muscles have immediate explosive energy.
But the textbook presents a fascinating paradox here. It lists a depressed immune system as an expected sign of acute stress. However, just a few paragraphs later, it lists an increased risk for infection as an expected finding of prolonged stress.
On the surface, those sound like the exact same physiological event. Why are they categorized differently for the exam?
The underlying timeline of the biological response dictates this distinction. When the acute fight-or-flight response is triggered, the body acts like a triage nurse in an emergency room. It immediately diverts all available energy away from non-essential long-term survival functions.
Like digestion.
Right, digestion halts. And the immune system is actively put on pause. It is physiologically depressed by the sudden flood of hormones. Because if you are running for your life from a bear in the woods right now, your body does not care about dedicating cellular energy to fighting off a potential rhinovirus you might catch next week. Immediate survival overrides long-term maintenance.
That triage analogy makes perfect sense. The immune system is shut down to save energy.
However, you do not instantly develop a bacterial infection the very second your immune system pauses. It takes time for pathogens to multiply. It is only when that stress state becomes prolonged, When the individual remains in a state of high alert for weeks, months, or years, and the immune system remains chronically depressed, that the physical result manifests.
So that prolonged suppression leads to the actual measurable increased risk for infection. Prolonged stress is the silent killer, because the human body was never evolutionarily designed to sustain high blood pressure, elevated heart rates, and massive glucose utilization indefinitely. It is like running a car engine at the red line for a week straight. Eventually, it burns out.
The chronic presence of cortisol leads to systemic inflammation. Prolonged stress brings chronic, debilitating anxiety, panic attacks, extreme weight changes, completely erratic diabetes control due to constant glucose dumping, and a massively heightened risk for myocardial infarction and cerebrovascular accidents.
The vascular system literally degrades under the constant pressure. Therefore, nursing interventions regarding stress management are not just about making the patient feel emotionally better. They are critical medical interventions to prevent systemic physiological collapse.
Most of the nursing care here involves extensive teaching of stress reduction strategies.
Let's explore the cognitive techniques first. We discussed this concept briefly when comparing therapies: cognitive reframing. This is the deliberate process of identifying irrational, catastrophic thoughts and actively restructuring them into realistic, balanced positives.
It is essential to emphasize that cognitive reframing is not about imposing toxic positivity or blind optimism. It is about demanding objective realism from your own brain.
Give us an example.
If a client faces a setback at work and states, "I am a complete failure and I will never succeed at anything," the nurse helps them identify the irrational generalization. They reframe it to, "I made a specific mistake on this project, which is frustrating, but I have a history of successful projects and I can learn from this error to improve."
You take the global, permanent catastrophic failure and reshape it into a specific, temporary, manageable challenge. You are physically changing the neural pathways of how the brain interprets failure.
That handles the cognitive side. Now let's review the behavioral techniques.
Your quick reference list for the exam includes meditation, guided imagery, deep breathing exercises, progressive muscle relaxation, and physical exercise.
But there's a massive glaring red flag in the text. A critical nursing judgment warning regarding these relaxation techniques.
This is a crucial safety parameter. You must carefully determine if behavioral relaxation techniques, particularly guided imagery and meditation, are appropriate for clients who are currently experiencing acute manifestations of a psychotic disorder.
This is so important.
On the surface, meditation seems completely harmless. Why wouldn't we want a patient diagnosed with schizophrenia who is highly agitated and actively hallucinating to close their eyes and do guided imagery?
Because we must consider the internal reality of acute psychosis. When a patient is actively psychotic, their internal world is profoundly disorganized, chaotic, and frequently terrifying. They are struggling to differentiate between reality and their hallucinations.
I see.
If you instruct that patient to close their eyes, turn their focus entirely inward, and utilize their imagination, you are systematically removing their sensory anchors to external reality. Left alone in the dark with their own mind, the hallucinations or delusions can intensify dramatically.
You are essentially locking them in a room with their demons. Patients in acute psychosis need concrete interventions that ground them fiercely in the present, external, shared world.
They need to hear your voice, feel their feet on the solid floor, and interact with tangible objects, not techniques that pull them deeper into an unpredictable internal landscape.
That clinical distinction can prevent a severe escalation on the unit. Let's look at 3 other highly specific stress management techniques: biofeedback, mindfulness, and assertiveness training.
Biofeedback feels very modern. It involves utilizing a highly sensitive mechanical or electronic device, like a clinical heart rate monitor, an advanced smartwatch, or a blood pressure cuff, to provide the patient with real-time data about their autonomic functions.
The patient watches the screen and actively learns how changing their breathing patterns or muscle tension physically lowers the numbers on the monitor. It provides visual proof of their internal control.
Mindfulness, deeply rooted in Eastern philosophy, involves using the physical senses to stay strictly and non-judgmentally anchored in the present moment.
Instead of ruminating on the regrets of yesterday or catastrophizing about the anxieties of tomorrow, the client focuses entirely on the physical sensation of the warmth of the sun on their skin or the specific sound of the wind, training the brain to exist only in the now.
And then there is assertiveness training, which teaches clients a specific framework to communicate their boundaries and needs, thereby directly decreasing external interpersonal stressors.
Assertiveness is frequently misunderstood, right? It is not about being aggressive or dominating a conversation.
No, not at all. It is about expressing one's feelings, needs, and boundaries in a direct, honest, and respectful manner that honors both oneself and the other person.
Let's apply this to a clinical scenario for the NCLEX. Imagine a client is experiencing profound stress because a colleague consistently attempts to offload their own work onto the client. The client is resentful but afraid of conflict. What is an assertive response the client can be taught to use?
The most effective formula is, when I am repeatedly asked to pick up extra work that is not mine, I feel incredibly overwhelmed and frustrated. I need to focus entirely on my own responsibility, so I cannot take this on.
Analyze the structural architecture of that response. It uses the "when you do X, I feel Y, I need Z" formula.
It addresses the specific observable behavior without launching a personal attack on the colleague's character. It clearly states the emotional impact, and it establishes a firm, actionable boundary.
Now, why shouldn't the client just ask, "Why do you always expect me to finish your work for you?"
In psychiatric nursing and in the foundation of all therapeutic communication, we actively avoid asking why questions.
Right.
Asking why implies judgment and criticism. It immediately forces the other person into a defensive posture, demanding they justify their actions. It almost guarantees an escalation into an argument and rarely leads to a productive, de-escalating resolution.
The word "why" is an interrogation, not an invitation. And on the flip side, the client shouldn't say, "If you don't stop giving me your work, I am going to report you to human resources and get you fired."
While that might stop the behavior, it is an aggressive threat designed to intimidate and harm rather than an assertive boundary designed to protect.
Recognizing that subtle but vital difference is key for the exam. Also, drill those biological timelines into your memory. A depressed immune system, sudden spikes in blood pressure, and acute apprehension are immediate stress responses. The development of chronic pain, recurrent panic attacks, and actual infections are the hallmarks of prolonged systemic stress.
Understanding the biological timeline of how symptoms develop is the key to successfully navigating those notoriously difficult select all that apply NCLEX questions.
We have covered immense ground, but we must face the reality of the field. What happens when the cognitive reframing isn't enough?
It's a tough reality.
What happens when the stress and the trauma coalesce into a severe, treatment-resistant psychiatric disorder? When a patient is suffering from profound, paralyzing, major depressive disorder, and the behavioral therapies and the complex cocktails of psychotropic medications simply are not working.
When the brain is locked in a state of chemical gridlock, we turn to the heavy hitters. Let's examine brain stimulation therapies.
These represent advanced, highly effective, yet often misunderstood non-pharmacological treatments. The most prominent, and undoubtedly the most stigmatized due to decades of horrific media portrayals, is electroconvulsive therapy, or ECT.
The cultural baggage associated with ECT is massive. Almost everyone instantly thinks of the barbaric scenes from One Flew Over the Cuckoo's Nest.
Absolutely.
But modern clinical ECT is an incredibly sophisticated, tightly controlled medical procedure. The textbook defines it as utilizing an electrical current to deliberately induce a brief controlled seizure while the client is fully anesthetized and paralyzed.
And the neurobiological theory is that this induced seizure activity acts as a profound systemic reset, enhancing the effects and availability of critical neurotransmitters, specifically serotonin, dopamine, and norepinephrine in the brain.
It is akin to rebooting a frozen computer system. The indications for prescribing ECT are highly specific and often life-saving. It is a primary intervention for major depressive disorder when multiple trials of medications have failed to produce a response.
Crucially, it is utilized when a severely depressed, actively suicidal client requires a rapid, immediate therapeutic response.
Antidepressant medications can take 4 to 6 weeks to reach therapeutic blood levels. Sometimes a patient in acute crisis simply does not have 6 weeks to wait.
The speed of ECT can literally save a life. It is also indicated for specific, severe presentations of schizophrenia, particularly those involving catatonic manifestations where the patient is immobilized and uncommunicative, and for severe bipolar disorder presenting with rapid, uncontrollable cycling between mania and depression.
Now, regarding contraindications, are there patients who absolutely cannot safely receive ECT?
The clinical literature states there are no absolute contraindications. If it is the only way to save a suicidal life, the medical team will find a way. However, There are conditions that carry exceptionally high risk, primarily involving the cardiovascular and cerebrovascular systems.
We are talking about patients with a recent myocardial infarction, severe heart failure, or a history of cerebrovascular accidents like a stroke or brain tumor.
Why do these specific conditions make ECT so incredibly dangerous?
Because inducing a generalized seizure, even while the patient is under deep anesthesia, puts a massive, explosive physiological demand on the body. The seizure activity temporarily causes a severe spike in heart rate and blood pressure, significantly increasing the workload on the heart.
And furthermore, it sharply increases intracranial pressure and forces massive amounts of blood flow to the brain. If a patient's cardiac muscle or cerebral blood vessels are already damaged or compromised, that sudden, massive hemodynamic spike can induce a secondary heart attack or a fatal stroke.
Also, it is vital to note for your exam parameters, ECT is not utilized as a treatment for substance use disorders or personality disorders.
That is a critical boundary to remember. Now, let's walk through the actual procedural nursing care, because managing an ECT procedure requires extreme precision. I view the medication administration for ECT as a highly choreographed, high-stakes dance. The timing of each drug is everything.
The choreography begins before the patient even enters the suite. Any benzodiazepines the patient is currently prescribed must be systematically tapered and stopped well in advance of the procedure.
The pharmacology logic there is simple. Benzodiazepines are potent anti-seizure medications. They raise the seizure threshold. The entire goal of ECT is to cause a seizure.
Exactly. If the patient has benzos in their system, the psychiatrist will have to use dangerously high levels of electricity to break through that medication barrier to induce the seizure.
Then, approximately 30 minutes prior to the actual procedure, the nurse administers an intramuscular injection of either atropine sulfate or glycopyrrolate.
This step is absolutely crucial for patient survival. Atropine serves two vital functions here. First, it is an anticholinergic. It rapidly dries up the body's secretions.
Because the patient will be paralyzed and unable to swallow, drying the saliva prevents them from aspirating fluid into their lungs.
Second, and equally important, atropine counteracts vagal nerve stimulation. The electrical current of ECT can stimulate the vagus nerve, which can cause severe, profound bradycardia, a massive, dangerous drop in heart rate. The atropine protects the heart's rhythm.
Once the patient is protected, the anesthesia provider initiates the procedure. They administer a short-acting intravenous anesthetic, typically etomidate or propofol. The patient rapidly loses consciousness.
Immediately following the anesthetic comes the most critical medication for exam purposes. The muscle relaxant, succinylcholine. This drug will undoubtedly be on your NCLEX.
Succinylcholine induces complete paralysis of the client's skeletal muscles. Why is this necessary? Because without it, the electrical current would trigger a massive, violent, tonic-clonic physical convulsion.
The sheer force of those uncontrolled muscle contractions could literally fracture the patient's spine or tear their muscles from the bone. Succinylcholine ensures the body remains perfectly, peacefully still, while the seizure activity occurs only within the neural pathways of the brain.
But the administration of succinylcholine introduces a profound nursing responsibility. The drug paralyzes all skeletal muscles, which includes the diaphragm and the intercostal muscles.
It paralyzes the ability to breathe.
Precisely. Therefore, the moment the succinylcholine takes effect, the patient cannot breathe independently. The nurse or the respiratory therapist must immediately step in and assist with respirations, delivering 100% oxygen using a bag valve mask.
They must breathe for the patient until the short-acting medication wears off and spontaneous respirations return. Throughout this entire process, continuous EEG monitoring is required to visually track the brain seizure, and continuous ECG monitoring is mandatory to track the heart's response.
It is an intense, incredibly tightly controlled medical environment. Now, once the seizure ends and the medications wear off, what happens post-procedure? What are the expected complications we need to educate the family about so they don't panic?
The primary universally expected findings immediately following ECT are short-term memory loss and acute confusion. Specifically, patients often experience retrograde amnesia. They might completely lose their memories of the events immediately leading up to the procedure, and they will have no memory of the procedure itself.
Therefore, the priority nursing action in the recovery room is providing frequent, gentle orientation to time and place and maintaining a strictly safe environment. You cannot leave them unattended. You cannot let them wander off the unit while their brain is rebooting and they are disoriented.
Now, while ECT is the oldest, it isn't the only brain stimulation therapy available today. We also need to understand transcranial magnetic stimulation, or TMS.
TMS is a fascinating leap forward in targeted technology. It is entirely non-invasive. It utilizes an electromagnet, roughly the strength of an MRI machine, placed precisely on the client's scalp to send highly focused magnetic pulsations directly into the cerebral cortex.
It is primarily prescribed for major depressive disorder that has not responded to initial pharmacological treatments. But unlike ECT, TMS does not induce seizure activity.
The logistics of TMS are completely different. It is an outpatient procedure. The client walks into a clinic, sits in a chair, and remains fully alert and awake the entire time. There is no anesthesia, no propofol, no acetylcholine, and no need to breathe for the patient.
A typical session lasts about 30 to 40 minutes, and it is usually prescribed daily for a period of 4 to 6 weeks. Because it is so targeted, the side effects are incredibly mild. Patients might report a tingling sensation on their scalp at the site of the magnet, or perhaps a mild transient headache.
It avoids the massive systemic shock of ECT. And finally, bridging the gap between psychiatry and neurology, we have vagus nerve stimulation, or VNS.
The concept of VNS is wild to me. It is essentially a pacemaker designed for the brain. It involves a surgical procedure where a small device is implanted under the skin on the patient's left chest. A wire is threaded under the skin up into the neck, where it is wrapped directly around the left vagus nerve.
The device delivers programmed electrical pulsations directly to the vagus nerve, which carries that signal up into the brain to continuously enhance the production of antidepressant neurotransmitters.
It is indicated for severe depression that has fiercely resisted both extensive medication trials and ECT. Once implanted, it delivers these pulsations around the clock, usually firing for 30 seconds every 5 minutes.
But understanding the side effects requires you to visualize the anatomy. Because the implanted lead wire is physically wrapped around the vagus nerve in the neck, it sits immediately adjacent to the larynx and pharynx.
Therefore, the adverse effects make total anatomical sense. When the device fires its electrical pulse, the client might experience noticeable voice changes, temporary hoarseness, localized throat pain, sudden coughing fits, or mild dyspnea, particularly if they are engaging in physical exertion while the device fires.
The engineering of the device includes a brilliant feature to mitigate this. The client is provided with a specialized external magnet. If they're about to engage in heavy exercise, or if they need to give a public speech and cannot risk their voice suddenly going hoarse, they simply place the external magnet over the implant site on their chest. The magnet temporarily deactivates the device, giving them control over their symptoms.
That intersection of technology and biology is stunning. Let's solidify this final section with some clinical hypotheticals. Imagine you are the nurse prepping a patient for ECT. The anesthesiologist asks you to confirm the purpose of the acetylcholine they are about to push.
Your response must be precise. Acetylcholine is the paralytic muscle relaxant. Its sole purpose is to completely paralyze the skeletal muscles to prevent the violent physical convulsions that would otherwise shatter bones during the electrically induced brain seizure.
If you are charting your post-ECT assessment in the recovery room, which of the following findings would you document as expected, normal outcomes, versus adverse events that require physician notification? The options are profound memory loss, acute confusion, paralytic ileus, and sudden hypotension.
You would document the memory loss and the acute confusion as completely expected, standard findings as the brain recovers from the seizure. Paralytic ileus, a blockage of the intestines, has absolutely no relation to the ECT procedure.
And crucially, you would notify the physician immediately regarding hypotension, because the expected cardiovascular response immediately following ECT is significant hypertension, a massive spike in blood pressure due to the sympathetic nervous system surge, not hypotension.
The details matter immensely. Final scenario. You're conducting a follow-up assessment on a patient who recently underwent surgical implantation for vagus nerve stimulation. Based on the anatomical location of the device, what specific adverse effects are you prioritizing in your assessment?
Because the wire is wrapped around the vagus nerve in the throat, you must specifically assess for structural interference, noticeable voice changes, persistent hoarseness, sudden coughing, and localized neck or throat pain.
Well, we have covered an immense expanse of clinical territory today. Let's take a moment to synthesize this entire deep dive. We started our journey on Freud's iconic couch, exploring the unconscious depths of psychoanalysis, the risks of boundary-crossing countertransference, and the modern shift to interpersonal psychotherapy.
We examined the behavioral rebellion, detailing how Pavlov and Skinner's theories translate into modeling, token economies, and the neurobiological habituation of flooding.
We waded into the complex, often toxic webs of family dynamics, learning to clinically identify manipulation, enmeshed boundaries, and the destructive geometry of triangulation.
We zoomed deep into the biological mechanics of the HPA axis and the fight-or-flight response, fundamentally differentiating how acute stress temporarily depresses the immune system to save energy, while prolonged stress destroys it, leading to infection.
And finally, we navigated the high-stakes, technologically advanced realm of brain stimulation, decoding the intricate medication choreography of ECT, the targeted magnetism of TMS, and the anatomical realities of the VNS brain pacemaker. You now possess a comprehensive, deeply prioritized study guide for traditional non-pharmacological therapies.
And if we step back and connect all of these seemingly disparate therapies to the grand overarching picture, there is a profound unifying scientific theme here. It isn't explicitly bolded or named in the chapters of your textbook, but it is the absolute biological foundation of everything we have discussed today. That theme is neuroplasticity.
Oh, that is a brilliant connection. Unpack that for us.
Whether you are a nurse guiding a client through cognitive reframing, helping them consciously dismantle and rewire their irrational, catastrophic thoughts, or you are utilizing the strict parameters of operant conditioning to physically force the building of new neural pathways to support healthier social behavior, or whether a psychiatrist is utilizing the raw electrical power of ECT or the rhythmic pulsations of VNS to literally and physically shock the brain into producing life-saving neurotransmitters, every single one of these interventions proves as one miraculous, undeniable biological fact. The human brain is never truly fixed. It is never permanently broken. The mind is not a static object. It is a constantly evolving, highly adaptable ecosystem.
So what does this ultimately mean for you, the nursing student, the future clinician? It means that whether you are standing in a chaotic acute care unit, treating a patient who is paralyzed by severe treatment-resistant depression, or you are simply a human being trying to navigate the stressful enmeshed dynamics of your own family during a holiday dinner, understanding these non-pharmacological tools means realizing you possess the actual capability to alter the architecture of human thought. You have the knowledge and the power to literally help change the physical shape of a mind.
It is an incredibly profound clinical responsibility, and simultaneously, it is the greatest, most enduring source of hope in the field of psychiatric medicine.
So, think back to how we began this journey. We talked about the comfort of broken arms and the certainty of X-ray machines. In mental health nursing, you will never get a clean, illuminated piece of film showing you exactly where the soul is fractured. The diagnostic waters will always be muddy, but as you have learned today, you do not need an X-ray machine when you possess the therapeutic communication skills, the behavioral conditioning frameworks, and the sharp clinical judgment to help a patient rebuild the house of their mind from the ground up. Take a deep, slow, diaphragmatic breath. Trust your knowledge, go ace that exam, and keep diving deep.